Welcome everyone. Thank you for signing up for this webinar. We will be looking at standards. As a colleague of mine has always enjoyed saying, standards are about the 5 B's. But what we want to know today is how many of these are actually backed by research? What is the evidence base? We talk about cardiovascular, pressure relief, the upright posture for social development and vision, but what is actually there in the research? Now, there's different levels of evidence, and the Center for Evidence-Based Medicine has an excellent chart delving into those facets of research. But it's important to know that the systematic review is your best top level of evidence, whereas your mechanism-based reasoning, just inferring intervention with outcome, is less so. As we think about the systematic literature review, the researchers have retrieved all the articles available and critically evaluated them and then synthesized that into something meaningful for the field. Randomized controlled trials are very important because in these studies, the subjects have an equal chance of being assigned to any of the study groups. So there's no even unintentional bias on the part of the researcher. As we look at these systematic reviews, we discover that the evidence is moderately strong for the use of supported standing for bone mineral density, and it is also showing support for decreasing tone and improving range of motion. Those other benefits, either the research is done poorly or it's not statistically significant, in effect inconclusive. This doesn't mean that those other benefits don't exist, it's just that we need more research. Today, we're going to be looking particularly at these facets of the benefits of standing that have been borne out by research. And this 2013 systematic review actually puts out some clinical recommendations based either on the research or some expert opinion in order to give you ideas for timing and frequency and dosing. Before we start, we just want to quick refresh the gross motor function classification system. I particularly want to point out that levels 1, 2, and 3, those children are able to functionally walk, whereas levels 4 and 5, they are more dependent. Here we see children who are ambulating. Here we see children who rely on adaptive devices. And this does make a significant difference in terms of development. Let's talk about tone first. Already back in 1990, the research was done on children with cerebral palsy. We know they all had spastic cerebral palsy. We don't know exactly the GM-FCS level. It hadn't been developed at that time. But we see that a half-hour prolonged stretch is resulting in a reduction of tone that is temporary, but does last even beyond the stretch. 20 years later, another study. This was looking at 6 children. They were ambulatory. However, they were provided the opportunity to stand in a prone stander. And during those weeks of the study that they actually had the standing time, the gait measurements and the tone assessment showed improvement. There was a reduction of tone, and specific parameters of gait actually improved when they had that standing opportunity. Notice the peak dorsiflexion angle improved. That could be considered a finding of range of motion. And that is what we are discussing next. Essentially, we see that standing can have an impact on contracture. These children had their knee extension range of motion measured. This was the same group of children, but again, they had time, a stretch of time, 6 weeks of PT alone, and then another stretch of time, 6 weeks with PT and standing. And during those intervals of standing, their knee range of motion improved and actually decreased when they did not have the standing opportunity. There was some caregiver reporting of ease of management of the children when they had the standing opportunity as well. Now, in saying this, we do need to make sure we don't have our blinders on We need to think bigger than simply range of motion and contracture and stretch. We have to recognize that it's about muscle and muscle growth and physical activity. And this is an excellent review because it reminds us that just like the osteopenia that is seen in bone of children who are inactive is actually a result of that physical inactivity, similarly, it may be that the contractions that we're seeing is actually due to muscle growth limitations and muscle strength limitations. So I invite you to read that article as well. Now we'll look at bone mineral density. This is one of the strongest evidence-based reasons to stand. We definitely know that children with cerebral palsy present with low BMD, and that is associated with fracture risk. And a number of cohort studies have been done on this particular topic. This is where we have a larger population of children who are observed over time. With the prospective study, they start in the present, and then they continue to follow them forward and compare those outcomes. With a retrospective study, they're actually looking backward in time to determine what factors may have influenced the outcome. But in every case, because it's a larger population of children, this is considered a higher level of evidence. It comes just under the systematic reviews in terms of levels of evidence. Here we see a study where children were followed for 9 years, and the data that was collected involved GMFCS level, gastrostomy tube for feeding, use of a standing device, and they had some interesting findings, including that children who were non-ambulatory but who used standards had a 4-fold reduction in fractures. A meta-analysis uses statistical methods to analyze multiple studies. It's a subset of a literature review. This 2017 meta-analysis confirms that weight-bearing exercise has a significant effect on improving bone mineral density. Now, in saying all of this, we need to take a closer look at that standing. Is it passive? Is it active? And a case control study is when you have 2 groups of subjects and they're each exposed to different interventions, and then you compare those outcomes. And this comes under cohort studies in terms of levels of evidence, but it's still valuable and provides information for us. Here we see that children who are in a stander where the foot plates mimicked the movement of ambulation, that actually generated an improvement in bone mineral density. Yes, it was a small study, the numbers of children were small, but it's exciting to see these findings. And it underscores that the forces experienced during ambulation are important. Now, a case series is where there's no control involved and you're simply observing outcomes with a particular group. This next study is really an observational study about how much weight bearing is happening with students in standers. And I'm not sure if we can really categorize it as a case series, but it's very interesting. What happened is young adults and children of GMFCS levels 4 and 5 were placed in a Rifton supine stander and in an easy stand. And the same subject was assessed in each stander, and there were special load measuring foot plate adapters that could assess the amount of weight bearing that was happening. And interestingly, there was quite a difference in terms of actual weight bearing in the stander. So this reminds us that in our positioning of students in standers, we need to make sure that that weight bearing is in fact actually happening. Now we'll discuss hip stability. And it's certainly widely known that children, particularly non-ambulatory children with cerebral palsy, are susceptible to hip displacement. In fact, one study showed that up to 90% of children of level 5 were experiencing this. So as we notice this happening, even with very young children, and predominantly with a spastic CP, we need to consider what are the factors involved here. So Sweden particularly has been a forerunner in looking at this more closely, and they've published both a 10-year study and a 20-year time span cohort study, and they're finding that indeed this is a high-risk population. When we talk about migration percentage, we're talking about the displacement of the head of the femur relative to the acetabulum. So the higher the portion of the head of the femur beyond the acetabulum, the greater the migration percentage, until you have a 100% when it's completely dislocated. And in 2009, Robin gave a classification where he put together his view that beyond 30% would be considered subluxed. Of course, every researcher will define the migration percentage as a way of showing that displacement. And this study was looking at children to find what are the factors that would predict developing that migration percentage within 5 years of that first X-ray. Interestingly, the factors were the migration percentage and the head shaft angle, so the coccyvalga at the hip, as well as the GM-FCS level. These played out in terms of high MP. Clinically evaluated hip range of motion, not so much. So Robin is looking at, again, these same factors at the hip, the femoral neck anteversion and the neck shaft angle, and these are found to be related to displacement of the hip. And what's fascinating about his work is that you can see the correlation between level 1 up to level 5 with an increasingly worsening deformity with that weight-bearing not being present and that muscle action at the hip not being present, as happens with gait. And that's just a stepwise fashion, quite impressive and thought-provoking, and definitely leads us to consider the shape of that proximal femur as being related to delayed walking and a key factor in dislocation. In fact, this study, which is about adductor spasticity and use of a hip abduction brace, concluded in the end that it's this bony deformity that may have a high rate of influence. And if we think about the idea of passive optimal positioning, as shown by this standing shell developed in Sweden, there's no movement. There's no active physical movement at the joint. And interestingly, they found that this non-dynamic weight bearing did not affect bone mineral density, and in fact possibly, or did indeed, worsen hip displacement in their study. These were children who did not have the opportunity to use botulinum toxin, so their adductor muscle group was quite spastic, and possibly those forces were stronger as the child was in this immobile position. So these are certainly considerations. Here on the flip side, we see a study where they actually had straddled abducted weight bearing. And this was a fairly high number of children. More of these children were in the control groups than were in the study groups. But basically, you can see the numbers there. Some of the children were post-hip surgery with abducted standing. Others were abducted standing only, potentially as a preventative measure for surgery. We do know that children with greater than 40% migration percentage are sometimes advised to undergo a adductor iliopsoas tenotomy, and that is what the surgery was in this case. And the findings were that certainly those in the abducted standing group had less migration percentage. Of course, we have to realize there are weaknesses of the study. For example, use of botulinum toxin was not controlled for either group, and potentially that aided the tolerance for the abducted position. Also, there were more children in the control group, which may have skewed the number of adverse response outcomes in that particular study group. But essentially we definitely recognize the importance of abduction. And the researchers themselves say larger studies are needed to confirm the results. So what does all this tell us? Postural management matters. And there have been various consensus and guidelines on postural management already over years, and that there are resources available with recommendations, some of which are linked directly to the research in terms of positioning for these children to optimize their outcomes conservatively. Of course, it is an approach that also will involve surgery as needed, and importantly, we need to think in terms of activity, environment, participation, looking far beyond simply the body structure and function for these children, which brings us to the ICF. And we cannot have a PT presentation without including the ICF. So there's a great learning tool online to learn more there. As we think beyond standing, we want to consider walking. This study actually looked at children and found that it was sit to stand that predicted walking. And there's a big difference between transitioning from sitting to standing and being placed in a passive standing position. And we also need to consider the young people's use of standers and what's important to them, their attitudes, the challenges they face. And this is a very nice study that you can read the full online text to learn more from the young people's perspective. So as we wrap up our discussion, we think about the fact that the reduced tone should lead us then to activities that would benefit from that reduction. Think about longer standing periods for range of motion benefits, and not to forget the importance of active muscle use as well. And then bone mineral density, assuring that the weight bearing is truly occurring, perhaps incorporating sit to stand as beneficial as well. Hip stability, definitely consider that for your children with spasticity who are non-ambulatory. And this is a little tip showing how 60 degrees is in fact an isosceles triangle. So we're talking about a considerable amount of abduction in order to achieve 60 degrees at the hip. We're now going to move from this segment to actually looking at some equipment, some of our Rifton products. So stay with me. So this is Rifton's supine stander. This one is the small. We also offer a large supine stander. You'll notice that the movement from horizontal to vertical is gradual. And with our large supine stander, you actually have some height elevation in the horizontal position to enable better ease of transfer. But you can imagine this stander being appropriate for a medically fragile child. Perhaps spinal cord injury on a ventilator, where you need to move slowly from supine to vertical without the risk of orthostatic hypotension. Remember, many of these medically fragile children have low bone mineral density. You'll want to position carefully to avoid risk of fracture. So we have great accessory support: head, trunk, knee, and sandals. On the small supine stander, the slots are horizontal. So you'll want to think about your positioning for your trunk. On the large supine stander, they are vertical, allowing for more infinite positioning and the possibility of putting a lateral on the same level as the strap. We do offer a lateral. It is a more oval shape, and it has a single knob, which can be used as trunk support as needed with the small supine stander. You'll notice that the knee supports are Velcro, so they can be moved up and down as needed in these slots. Think about positioning it either above the knee or below the knee, and your considerations might be the amount of contracture, the amount of vertical positioning of the board, because the purpose will be perhaps to add a little stretch for range of motion, or adding some support at the knee for weight-bearing assist. Probably you want to avoid placing it directly over the kneecap because of that compression between the patella and the femur. But there again, use your clinical judgment in each case. There's a lot of factors involved. Now we'll take a closer look at the sandals. The sandals are actually placed on a base, and this base can be moved forward, back, in and out, and even some rotation. Clearly, what we want to find here is a means of promoting weight bearing for bone mineral density. And that is going to be about careful positioning of your accessories to make sure that the weight is coming through the foot to the sandal. Some clinicians actually like to attempt to just move that foot slightly. And if it moves very easily, that's an indication that they're not doing a whole lot of weight bearing through the foot. These straps you can attach across, if preferred, to assure that the foot is held in place. And we do also have wedges which can be secured right under the sandal itself. These have an angle either to accommodate plantar flexion or to accommodate a little more dorsiflexion to add to that stretch at the foot. And just make sure that the latches are in place. We have some further options for leg separation. These include a simple abductor, which is placed in the central slot. Also a round abductor with the knob offset so that you can simply and easily rotate that to get just the precise position you're looking for, as well as moving it up and down. And it has an optional collar to add diameter. So one consideration with this tray for the supine stander is that you'll want the armrest to be equidistant from the top of the bar to the knob on both sides. And you might even want to make a little black marker notation for a particular student if that's important in a given case. Then to place the tray on, you'll simply pull out the latch and secure it into the holes on the side. And then once the tray is in place, you can then do further adjustments with this lower knob to modify your angle as needed depending on the position of the board of the supine stander. For a smaller child or a child who no longer needs the head support, it is possible to simply adjust this bar and drop that out of the way, and then raise the footboard up. And you'll notice immediately that we are now accommodating for a much smaller child. And these same round laterals can now become head supports if needed, or be used for the trunk or even between the legs as indicated. So this is Rifton's prone stander. This is the small. We also offer it in medium and in large. Again, we have the gradual change of angle. With our protractor here, you can see it can move right up to 90 degrees, or you can have it at a slightly less vertical setting. Just realize that the more horizontal it is, the more the body weight will be supported by the trunk board, and less weight bearing will occur through the long bones. Whereas as you move it into a more vertical position, you can check and assess whether you're able to assure that the client is really bearing weight through their legs. Here we have two straps on the small that will cross for that postural support. On our larger standers, these straps are simply horizontal across the frame. This is a separate knee board. So the knee board and the foot board and the trunk board all adjust in height separately. And that's very beneficial either to accommodate height of the child, or as they're gaining in upper trunk and postural control, you can lower the support. As you move into a more horizontal position, you're actually challenging the extensors, the head and upper trunk, to build that postural control against gravity. Now we're just going to have a look at the accessories. We have the laterals for the trunk, we have the knee supports, and again the sandals. Here the small sandals are mounted on the footboard, and I'll just compare them in size to the medium for your interest. So this then would be the medium sandal, and you can see how both fit onto this particular size of prone board. We again have that same stack and latch system. And another consideration might be that you'll choose to place the sandal this way around. And the concept there is that for the student who is able to step up onto the board in order to have that standing opportunity, it's actually easier for them to clear the board and place their foot onto the sandal. Now, a couple more pointers in terms of transfer into the product. Either you have a child who is able to step up onto the sandal themselves, or you may have the child positioned safely on your lap, place their feet into the sandals, and then stand up with them as a way to assist their transfer into the product and then secure them safely. Some further considerations include sizing of the stander for even smaller children. And in order to do that, you can actually remove the knee board. And I'll just show that step here. You loosen this knob and swing the little metal piece around. And now we are able to move the footboard a lot higher and slide that up those rods and make the entire stander suitable for a much smaller child. In terms of abduction or leg separation, we have similar options as we saw with the supine stander. The difference here is that we have now a hip stabilizer. And this, once it's secured in place, will actually assure a hip extension stretch for the child. Finally, a small look at the tray. It's a very nice smooth surface. This means that it will accommodate the Anchor product family from Rifton as a way to stabilize an upper extremity for better use of the hand that is free, and very simple angle adjust as needed for the board, depending on the angle of the board and tray for a particular student. So that wraps up our prone stander. So this is our mobile stander. It actually sells as a standalone product. The large wheels are added as an accessory. What you see here is the mini, and you'll notice that the footboard is higher off of the floor and the trunk support is smaller. The small actually uses the very same frame and same wheels, but the footboard is lower and the trunk support is larger. So as a courtesy, Rifton can mix and match the size of the trunk board and the size or height of the footboard as needed to accommodate certain children's needs. So bear that in mind. But essentially, the features that we're concerned about here are the trunk board, which is height adjustable through these knobs here at the front. So each size can accommodate quite a range in height. This is now the medium that we're looking at here. Then we also have the large wheels, and the beauty of that is that we essentially have a standing wheelchair. The child is able to mobilize themselves around their environment and get the health benefits of standing at the same time as moving around the room. This handbrake is within reach of the child. The large wheels can actually be popped off. There's a nice finger hold and thumb latch if you would need to have a smaller footprint in the classroom for whatever reason. We also then have our seat pad, and you'll notice there's 4 latches up the side of the trunk board, and that enables you some positioning options in terms of placement of this seat pad. Imagine a child who might be a double amputee, and you would like to angle that underneath the buttocks for a full weight-bearing support, and they could then be in upright position. Another diagnosis might be spina bifida, where you do want to assure some weight bearing through the limbs, in which case you might loosen these lower straps and have it more vertically placed. The other benefit of having 4 potential hook spots is that should you decide to use more than one seat pad, you can accommodate both. There's a larger seat pad as well as a secondary seat pad option as a back support. And again, you can mix and match sizes and placement of your seat pads thanks to those 4 available hooks. This is actually an upper trunk support, which can simply be placed across the back for some postural support. There are cases where this strap is fully lengthened and actually used as a support behind the neck, above the shoulders, for a student who may have extreme hyperextension. So that's something to bear in mind. As we look at the sandals, these move in and out, forward and back. You can also get some rotation. And we do provide a simple little wedge in some cases, should you need to either raise the heel up to achieve weight bearing or again get some dorsiflexion stretch. Finally, I'll just mention the mounting bar. And this secures into these knobs right at the front of the stander. And this gives you the option of actually using arm prompts. You may have a student who has very low head and trunk control. They may not be using the large wheels, and it would be preferred to place their arms in arm prompts in order to build some of that head and upper trunk control in this pier height position. On this very same mounting bar, you can also place the communication tray. For some children, this may also dual as a space for their arms to be placed as they're working on head control. Otherwise, it's a nice space for an iPad, for entertainment while they're in the standing position, or any other communication picture symbol type tool that they may use. And that's height adjustable and angle adjustable, as you know. So that wraps up the 3 styles of stander that are available from Rifton. We always value input from the field, feedback from the field. You know that our email is sales@rifton.com. Please let us know any thoughts you have also for future design.